Today we're going to talk about how cancer is diagnosed, staged, and graded. This is the part of oncology where science meets decision-making. Every treatment plan and prognosis begins with an accurate diagnosis. So let's walk through what that looks like. When cancer is suspected, patients go through a series of evaluations to answer some big questions. First, is cancer actually present? Second, if it is, how far has it spread? Third, how well are the body's systems functioning, both the ones that are involved and the ones that aren't? And finally, what kind of tissue are we dealing with? To answer those, we use a mix of physical exams, lab tests, imaging, and most importantly, getting tissue and cells for analysis. Now, think about what this means for patients. These tests can be frightening, not only because of the procedures themselves, but because of the possibility of bad news. This is where nursing comes in. Nurses play a critical role in explaining what the test involves, what the patient might feel, and what their role is in the procedure. We also listen to their fears, encourage questions, and clarify the information that providers give. Cancer diagnosis isn't just medical. It's deeply emotional, and nursing support makes all the difference. Once tissue is obtained, the next step is staging and grading. Staging describes the size of the tumor, whether it has invaded locally, whether lymph nodes are involved, and whether there's distant metastasis. The most widely used method is the T&M classification system. T stands for the size or local extent of the primary tumor, N stands for lymph node involvement, and M refers to metastasis. Each of those letters can be followed by numbers that describe increasing severity. For example, a T1 tumor is small, while T4 is large and invasive. N0 means no lymph node involvement, while N3 means extensive spread to regional nodes. M0 means no distant metastasis, and M1 means it has spread. It's a straightforward way of capturing a very complex disease. Grading is different. Where staging tells us how far the cancer has spread, grading tells us what the cancer cells look like under the microscope. Grade 1 tumors are well differentiated. They look a lot like the tissue they came from and tend to behave less aggressively. Grade 4 tumors are poorly differentiated or undifferentiated. They no longer resemble the original tissue, and they're usually more aggressive, less responsive to treatment, and associated with a worse prognosis. Most cancers fall somewhere in between. Once staging and grading are complete, cancers are often grouped into anatomic stage groups, usually labeled I through IV. This shorthand lets providers communicate quickly and consistently. Stage 1 generally means early, localized disease, while Stage 4 usually means advanced metastatic cancer. These categories help guide treatment decisions and allow providers to compare outcomes across populations. To get there, we rely on a whole toolbox of diagnostic tests. Tumor marker identification looks at biochemical substances in blood or tissue that are associated with cancer, though many markers can also be found in normal tissue. Genetic tumor markers are increasingly used to look at mutations that influence how a cancer behaves and responds to therapy. Imaging tests are also central. Mammography for breast cancer, CT and MRI for cross-sectional imaging, ultrasound for abdominal or pelvic tumors, and PET scans for assessing metabolic activity. Endoscopy allows us to directly visualize areas like the GI tract or bronchi, and even collect biopsies. Nuclear medicine scans use radioisotopes to detect areas of abnormal uptake. Even vascular imaging, where contrast highlights the blood supply to a tumor, can be essential before surgery. Each test has its strengths, and most patients will undergo several. The American Cancer Society provides specific screening guidelines for many cancers to catch disease early. For example, mammograms for women starting in their 40s, pap smears and HPV testing for cervical cancer, colonoscopies or stool-based tests for colorectal cancer beginning at age 45, low-dose CT scans for lung cancer in high-risk smokers, and prostate screening with PSA and digital rectal exams after informed decision-making. These guidelines are designed for people without symptoms, with the goal of detecting cancer early when treatment is most effective. At the end of the day, diagnosis is about more than identifying a tumor. It's about using science to paint a complete picture of the disease, so the right plan can be made for the right patient. And in every step, nurses are right there, explaining, supporting, and helping patients make sense of what can feel like an overwhelming process.